Very happy to welcome Scott Friedman to talk next. So Scott is Dean for Therapeutic Discovery and Chief of Division of Liver Diseases at the Icahn School of Medicine at Mount Sinai. So Scott, I know it's very early for you, so thanks for joining so early. So Scott's a graduate of the Icahn School of Medicine, then was a medical resident at Beth Israel Hospital at Harvard, followed by a gastroenterology fellowship at UCSF before assuming a faculty position, which he held for 10 years. So during a sabbatical from UCSF, he was senior Fulbright scholar and visiting professor at the Weizmann Institute in Israel. He's a fellow of the American Gastroenterology Association, the American College of Physicians, the AASLD, and the American Association for the Advancement of Science. And over the last 20 years, he's built the faculty up at Mount Sinai and currently consults for over 40 companies in the liver disease space. So Scott's talk is Diagnostic Challenges in Non-Alcoholic Fatty Liver Disease. Over to you, Scott. Thanks very much for joining us.
Hello, this is Dr. Scott Friedman at the Icahn School of Medicine at Mount Sinai. Delighted to give a lecture on diagnostic challenges in non-alcoholic fatty liver disease for the Breath Biopsy Conference in November of 2020. These are my disclosures. I have many interactions with pharma and biotech companies, both across the therapeutic and diagnostic spaces. The problem of fatty liver disease is arising in the United States in parallel to and as a direct result of the rising epidemic in obesity. You see this map of the United States depicting states that have progressively increased prevalence of fatty liver disease. Most notably, those in deep red indicate states that have at least 35% or more of their population qualified as obese. As you can see, between that and the lighter red states, over half the United States have populations with soaring rates of obesity. And this will lead to an exponential rise in associated fatty liver disease. Currently, 65 million Americans have non-alcoholic fatty liver disease, which is likely to rise to 100 million within 10 years. At least 16.5 million now have NASH. This will rise to 27 million by 2030. And hepatocellular carcinoma will almost double during that interval. Scarring of the liver is really a chronic wound healing response to injury of many types. Most commonly in the United States and throughout the world, those include hepatitis virus infection, non-alcoholic steatohepatitis, alcohol, as well as a whole host of other chronic inflammatory disorders. For today, I'm going to focus entirely on non-alcoholic steatohepatitis and its association with fibrosis and the challenge of developing non-invasive diagnostics to stage and detect this disease. In fact, non-alcoholic steatohepatitis is part of a spectrum or progression of disease that starts with fat or steatosis, often called non-alcoholic fatty liver, then progresses to an inflammatory or fibrotic stage known as NASH, and may progress to cirrhosis. Interestingly, the patients who have fat alone are not thought to be candidates for liver-directed therapy at present, and so most of our attention is focused on NASH patients who have an inflammatory disorder with a risk of progression to cirrhosis. One other critical point is that NASH is relatively unique in that hepatocellular carcinoma can also arise in patients with NASH who do not yet have cirrhosis, in contrast to most other chronic liver diseases where cirrhosis typically must be present for cancer to arise. And that it has implications for earlier screening for hepatocellular carcinoma in advanced NASH, even before they are cirrhotic. When we do liver biopsy in patients with suspected NASH or non-alcoholic fatty liver disease, there are three major components: the amount of fat or steatosis, lobular inflammation, as well as ballooning. These are pathologic features that are assessed semi-quantitatively by qualified pathologists and added as a separate score in parallel to the amount of fibrosis. What's interesting is that the three components of the NAFLD activity score were developed not because they were most predictive of outcomes, but rather because they had the highest degree of inter-observer agreement among pathologists using these scoring criteria. One of the reasons we're moving away from the non-alcoholic fatty liver disease scoring system is because in the end, of all the components of the biopsy, the only one that correlates predictably with outcomes is the presence and severity of fibrosis. What you're looking at here is a study almost 10 years ago that established that based on the stage of NASH fibrosis, outcomes were dramatically different. Those patients in the upper line who had a NASH fibrosis stage of 0 had virtually no clinical outcomes of death, whereas those patients at the other end of the spectrum, who in the solid line, who had advanced fibrosis, had about a 45% risk of death or a 55% survival, which translates into a very ominous sign. And so clinical trials now are focused much more on the amount of fibrosis than any of the other features of the disease. That's underscored by some data from a couple of years ago, looking at the outcomes in a negative trial for an antibody known as simtuzumab, which is a lysyl oxidase 2 antibody. The trial was negative, and so it allowed investigators to glean the natural history of the disease. And in fact, in a follow-up of a little over 2 years, 25% of patients with NASH and bridging fibrosis progressed to cirrhosis. That's quite a lot in a just 2-year period. Similarly, after a similar median follow-up, 20% of the cirrhotic patients decompensated further and had liver-related events such as variceal hemorrhage or hepatic encephalopathy or the development of ascites. And as I alluded to before, there was no predictive value to baseline NAFLD activity score or their changes over time. And again, this reinforced the fact that fibrosis or scarring is the primary determinant of disease progression and an acceptable surrogate endpoint in NASH trials, as we'll discuss. There are, in fact, there is an urgent need to develop non-invasive markers of NASH stage, in particular fibrosis. And so I'll walk you through some of the current efforts and the technologies that are being developed. 3 of the most common serum tests are the FIB4, the NAFLD fibrosis score, the European liver fibrosis test, and you can see the components of each of those on the left-hand column, as well as liver stiffness by FibroScan, which I'll talk more about in just a minute. And then finally, there's another technology, ProC3, which measures fragments of collagen that are liberated as fibrosis develops. And this had an area under the receiver operating curve of 0.78, but only a diagnostic accuracy for significant fibrosis of around 65%. So we know very well the thresholds for these non-invasive tests, particularly the serum as well as the FibroScan thresholds. But I think it's safe to conclude that these are simply not robust enough to be used as endpoints for clinical trials in and of themselves. Moreover, the sensitivity and specificity of 3 of these tests, AST, ALT, the NAFLD fibrosis score, as well as the FIB4 score, worsen with increasing age. And so you can see here in each of these tests, in the open circle lines, the specificity goes down dramatically as patients age past 50, and certainly as they get into their 50s and 60s. And so the age is an important determinant of whether these tests have any value at all. Another approach is to perform liquid biopsy. This effectively refers to the measurement of nucleic acids and other cellular constituents in the serum that can be quantified. One of the more well-validated tests that includes some nucleic acid has been developed by GenFit, which is a non-invasive fibrosis score comprised of the constituents you see here in green. And this has a specificity of 85% and a positive predictive value of about 81%. And so this is getting better, but whether this represents a diagnostic sufficient to track patients in response to therapies, particularly in the context of a clinical trial, I think remains unknown. There are also efforts to glean more information from the biopsy itself. One of the better approaches, or the better evaluated approaches, is something called second harmonic generation. Commercially, this is called HistoIndex. And rather than just quantify the amount of scar, this test also looks specifically at the features of that scar with respect to the size of the fibrils, the length of the fibrils, the width of the fibrils, and try to use this to get more sensitive information about extracellular matrix or scar deposition than a conventional biopsy can yield. However, since it's based on biopsy, like all biopsies, it's prone to sampling variability with one stage difference that can occur between different regions of the same liver, upwards of 50%. And that's a sizable consideration when relying on biopsy alone or even second harmonic generation. Second harmonic generation has been used in a limited number of studies. This is one example from Madrigal, which is testing a beta thyroid hormone agonist. In this trial, the conventional fibrosis scoring system did not change sufficiently, but using second harmonic generation, the investigators, in particular Stephen Harrison, could show that there was a dramatic improvement, as shown on the right-hand side, based on second harmonic generation, even though there was no significant difference in conventional fibrosis staging. And so whether this remains or is developed further and validated, I think is still unknown. There are other diagnostics that are potential endpoints in clinical trials. They include measurement of serum lipid constituents, in particular inflammatory lipids, FibroScan with an accompanying CAP score, MR technologies, and function tests. And I will review these each in succession. I will not talk about hepatic venous pressure gradient, which is a more invasive tool and really not amenable to widespread use in clinical trials. These are data from a platform developed by a commercial entity known as OWL, OWL, out of Spain, in which they measure about 20 different analytes, in particular inflammatory lipids, and look at the changes in those analytes based on the stage of the disease. So it turns out this platform appears to be very robust in distinguishing normal liver from NAFLD, and further, quite useful in distinguishing NASH, the more inflammatory form, from NAFL or fat alone, with very high area under the receiver operating curves. Trials are ongoing to determine whether, in fact, changes in these lipid abnormalities and the aggregate score correlate with improvement or worsening in disease, either spontaneously or in response to therapies. Another test that's widely used and already FDA approved is the so-called FibroScan. This is one technology that's part of a larger family of technologies that measure liver stiffness, collectively known as elastography, which can either be transient elastography in the case of FibroScan or shear wave elastography in the case of other technologies such as supersonic and other methodologies. The technology looks like an ultrasound, but in fact, the device is characterized by a vibrator that sends a pulse through the liver, and the speed with which that pulse travels through a region of interest correlates with the amount of stiffness. It's been approved by FDA since 2013. It takes just a few minutes, very reproducible across investigators, and one can use a separate adjunct to this technology called a continuation attenuation parameter, or CAP score, that can assess hepatic fat content. And it's generally been shown that stiffness of greater than 8.5 kilopascals with a CAP score of greater than 280 are suggestive of NASH with fibrosis. And as I mentioned, there are other technologies that also assess stiffness and have comparable performance as the FibroScan, albeit far less experience in the clinical setting. A more refined way to measure liver stiffness is demonstrated here and known as magnetic resonance elastography. As you can see, this captures stiffness across the entire map of the liver, and you can see progressive changes that are colorized from stage 0 to stage 4 being cirrhotic. In general, the magnetic resonance elastography has an ORAC of 0.8 for discriminating early from advanced fibrosis. Of course, this obligates the patient to come to an MR suite where the technology is available, and it can take anywhere from 10 to 30 minutes, depending on whether a full study is done or whether the MR technology is combined with other MR approaches at the same time. One other variation on MR technologies is developed by a company called Perspectum, which uses a corrected T1 weighted imaging map to assess therapeutic responses. These are data from a trial by a company known as NGM that is testing an FGF19 analog that looks promising in phase 2 trials. And what you can see here is that this combined corrected T1 imaging on the left-hand side shows improvement in fibroinflammatory levels within 6 weeks that correlates with biopsy, shown here under NAS or NAFLD activity score. Also in this clinical trial, the Perspectum technology appears to correlate with therapeutic or histologic response, with much greater reductions in corrected T1 among responders than Pro-C3 or ELF markers. Now, this brings us to a totally different concept and one where breath biopsies may have real promise. If we think about how other specialties assess fibrosis and look in particular to pulmonologists who assess lung fibrosis, we know that they assess disease state and progression not by the histology in the tissue, but by the functional reserve of the lungs. And so in general, pulmonary function tests correlate with outcomes, response to therapy, and are a widely used endpoint in clinical trials for drugs to treat idiopathic pulmonary fibrosis. One of the technologies that's being developed in a company in Colorado is HepQuant. This looks at the clearance of an administered cholic acid, both administered orally and through the portal blood, and now in NASH. With diseased liver, there is more shunting around the portal, through the portal vein and around the functional reserve of the liver, and this can be quantified and correlated with disease stage. Data are still somewhat limited in the context of therapeutic trials, but these are data that was presented at the European Liver Meeting as a sub-study as part of treatment trial using obeticholic acid, which is an FXR agonist. On the right-hand side, you see the histologic response compared to placebo in patients dosed with either 10 or 25 milligrams of obeticholic acid for 18 months. And on the left-hand side, you can see in a small number of patients that the functional improvement as determined by this discriminant shunt index was far more dramatic, both in the 10 milligram and the 25 milligram treatment dose. So these data at least suggest that there may be a dose response in this functional test consistent with the dose-dependent improvement in fibrosis observed in their phase 3 trial called Regenerate. And the company is now pairing with a number of different clinical trials to determine the value of this functional test of cholate clearance in assessing disease stage and response to therapies. Another completely separate conceptual approach is to assess the amount of proteases circulating in the blood in patients with NASH. This is from a company called Glimpse Bio, in which they've looked at the different proteases that are contributing to disease pathogenesis in NASH, including those that drive lipogenesis, inflammation, fibrosis, as well as cell proliferation. And what they are doing is developing or have developed a method to assess proteolytic activity in the serum based on artificial labeled substrates that they administer to the patient. That approach is depicted here. Patients are administered intravenously an exogenous molecule that is a pegylated substrate with different peptides that contain mass spec tags. The peptides also contain sequences that confer sensitivity to very specific proteases. And by administering these diagnostic molecular mix, one can look for excretion of labeled fragments of those different peptides in the urine and quantify that and try to correlate it with disease. And so these studies are ongoing. It represents a completely different approach, but a very clever one in trying to correlate the proteolytic activity of a defined mix of proteases with disease activity. So in summary, the challenge of diagnosis of NAFLD remains intense. There's an urgent need to develop non-invasive biomarkers that can avoid the requirement for biopsy. Here's where we stand so far. FibroScan with CAP score and blood-based markers, particularly the FIB4, ELF, and Pro-C3, are very useful in identifying advanced NASH fibrosis for clinical practice, but they are not sufficient as endpoints in clinical trials. Current clinical trials for NASH therapeutics can avoid biopsy for phase 2A trials that assess whether a drug is hitting its target. However, phase 2B and phase 3 registration trials for FDA approval still require biopsy for now. We believe that newer techniques alone or in combination are rapidly advancing. Those include potentially functional tests that might include breath tests as well, measuring the functional reserve of the liver rather than relying on direct or indirect assessments of histology and fibrosis content. We hope and predict that they will replace biopsy altogether for NASH staging within 5 to 7 years. Thank you very much for your attention, and I hope presentation will elicit some questions. Thank you.
Fantastic. Thank you so much for that, Scott. Really fantastic talk. So if you can start your camera and microphone, can you hear me okay?
Sure can. Can you hear me?
Yep, can hear you. Fantastic.
Good.
Yeah, thanks so much for that. So in the last slide there, you're saying that, you know, there's no approach that's quite there yet to allow to act as a surrogate endpoint in clinical trials. Is there a kind of firm or a target sensitivity and specificity that you think that will, you know, once you get there, you know, kind of mission accomplished type thing, or is that, you don't have that?
Well, certainly that's a fair question. It's nothing that the FDA has identified. I think from their perspective, they'll know it when they see it. From my perspective, I think we really want to see area under the receiver operating curves of close to 0.9 or better. That would be a working cutoff. But again, I think ultimately the arbiter, at least in the US, is the FDA or the EMEA. And I think they would not necessarily define a strict cutoff yet, but rather show that it has discriminating ability equal to or better than biopsy. It's worth remembering, Billy, that even biopsy is a surrogate. You know, the drugs that are seeking biopsy-based approval for NASH are applying under a subpart H, which means that it's a conditional approval because the test is reasonably likely to predict outcomes. The real endpoints are going to be outcomes themselves. So in other words, even if a drug is approved after phase 3 based on biopsy markers, the FDA, and I suspect the EMEA as well, will require that those companies show that not only does it improve the biopsy at the time of the clinical trial, but that subsequently in post-marketing studies, there's an improvement in outcomes based on continued treatment with the drug.
That's great, thank you. So you also mentioned the potential of breath tests. So obviously there's been a lot of work looking at stable isotopes with likes of companies such as Excellence, for instance. Right. Do you have a kind of feeling for whether or not the stable isotope type approach may get close to the type of performance needed and probably a bit harder to predict? You know, do you think exogenous probes, maybe of VC origin, could also be potential candidates though?
Right. Well, the C13 methacetin substrate that was developed by Excellence didn't get over the finish line in terms of discriminating ability. And to my knowledge, that program is not being further developed, which I was very disappointed about. And I think it reflected as much about an unclear development plan for many years as it did about any weaknesses of the technology. So as I implied in my comments, I think that to me, a breath test that can reliably reflect function and functional changes in the end is going to be more powerful in predicting outcomes than just the histology. And so I'm agnostic about what kind of breath test is most effective, but just to identify one that really correlates with outcomes. And I think these are going to be, you know, the lower hanging fruit for breath tests and functional tests are going to be in the more advanced patients who are at higher risk of decompensation within a defined period. I don't think breath tests are going to be nearly as attractive in patients with early stage fibrosis who are still a decade or two away from clinical events. Yeah. Instead, we want to know in advanced patients, are we really halting the tidal wave of decompensation in a reasonable amount of time, a year, 2 years, 3 years? And is that predictable by a functional test like a breath test?
That's really interesting. That's really interesting. We've got a follow-up question from Patrick. So you mentioned that only fibrosis stage is known to be prognostic in NAFLD. Yet FDA and EMA require phase 3 trials in patients with a combination of sign fibrosis, F2 or higher, and NASH, NAS of 4 or higher, at least 1 point in each component. Do you think this requirement will change in the near future? And what is needed to replace biopsy within 5 to 7 years?
Right. Well, I think what they're referring to is significant fibrosis. The current and moving paradigm for approval currently is either improvement in fibrosis or complete resolution of NASH based on biopsy criteria. And I think that's sort of where we've landed for now. The FDA has made it, I would say, been pretty consistent in saying that those are going to be the approvable endpoints for the foreseeable future. I would like to think that in 5 to 7 years, we can tease away the requirement for biopsy in some of these more advanced patients where we have functional markers that predict outcomes. But of course, those studies need to be done first. But I could imagine that if you do a study in a group of very advanced fibrotic or even cirrhotic patients, and you show a significant improvement in a functional marker, and then 3 years later, that translates into a reduced incidence of complications, that's the kind of pathway that I think ultimately will yield approval and attention. Of course, I'm not the FDA, so I'm loath to, to speak on their behalf, and I can't.
That's great. I think that's all the time we have for questions. Thank you so much, Scott.